Hello, everyone. Welcome to RheumNow's panel on psoriatic arthritis from EULAR 2024. I'm joined by the experts who were covering the psoriatic arthritis content at the meeting. In this panel discussion, we'll review for you our favorites from the meeting and get input from our colleagues on our thoughts and impressions. I'm Jack Cush in Dallas, Texas. I'm joined by my friends, so I'll let them introduce themselves.
Eric Ruderman from Northwestern in Chicago, Illinois.
And Peter.
Peter Nash from beautiful downtown Brisbane in Queensland in Australia, but not quite there at the moment, Jack.
Always making your way back home. And Anthony.
Hello, I'm Anthony Chan from London, United Kingdom.
Excellent. All right, folks. Let's begin with Anthony. And what did you like as your first choice?
Yep. First is the late-breaking abstract 002 from McGonigal and colleagues. This is a study looking at 5 different classes of biologics in PSA, the ProSpirit study with 1,000 over patients, and they looked at 24 months of the efficacy of the different agents, the TNF, IL-12/23, IL-23, IL-17, and JAK inhibitors. In summary, over the period of time, they found that the IL-17, namely ixekizumab, was as effective as TNF and JAK, but there were some differences. The treatment with ixekizumab brought on a faster improvement compared to IL-23 and also the IL-12/23 in terms of the CDAPS score. And also in terms of skin, in terms of the body surface area, this was better than a TNF. This is quite contrasting to another study which was also presented earlier in the conference, the OP0010 from the TriNet-X study, where they looked at people very early in psoriasis, where before they actually developed psoriatic arthritis. In that group, it seems that the IL-12/23 was better than TNF and IL-17. So I think these two studies perhaps tell us about the continuum between psoriasis to psoriatic arthritis to latent disease, that perhaps IL-12/23 or IL-23 inhibitors could be operating earlier in the disease in terms of the cytokine signaling. And later on in the disease, it seems like IL-17, TNF would be more effective. So I thought that was quite interesting, the LBA 02.
So controversial, isn't it? Eric, what do you think about this data and where is its real utility?
Yeah, so I let me follow on with one other abstract and then talk about it. And I think on top of the sonelokimab that Anthony just talked about, the other interesting late-breaking abstract was the one on a molecule called azokibep, which is not technically a nanobody, but it is another small protein targeting interleukin-17, in this case, just interleukin-17A and not A and F as the nanobody that Anthony talked about was. This was a phase 2b and 3 study. They'd done some phase 2 work before. It was a multi-center trial that looked at a couple different doses of this azokibep molecule versus placebo, and showed that it was quite effective with ACR 50 response rates at 16 weeks of about 40% in both arms, and an MDA response that was also about 40% in both arms. So an effective drug with also great skin response at about 50% PASI 100s. So it behaved a lot like an IL-17 inhibitor. And I think the interesting question is whether these sort of smaller protein IL-17 inhibitors are going to be any different than the antibodies that we've been using for some time, ixekizumab or secukinumab. With respect to the TriNet-X stuff that Anthony referred to, I actually will want to sort of push back on that one a little bit. I looked at that with some colleagues who know an awful lot more about epidemiology than I do. And the challenge with that particular database is that the data analysis isn't great. It
Mm.
it it isn't carefully done. It's a really interesting system where you can they sort of layer a dashboard on an existing database that pulls data from multiple EHRs, but it's not really well structured, and I don't know how well you can trust the data that's in there because it doesn't really control very well for confounders, and especially confounding by indication when people select drugs, because you're at the mercy of whatever drug that people are put on. So I would be a little cautious about using that to say that one pathway is better than the other. You know, what we don't have in psoriatic arthritis, and we desperately need are head-to-head studies
Mm.
comparing some of these newer targets, IL-17 and IL-23. We've had a couple head-to-head studies comparing IL-17s versus TNF inhibitors that both show the same thing, that they're equivalent for joints, but IL-17 inhibition is better for skin. But we don't have any studies with the newer agents. They have them in derm. They've done them in derm, so we know it can be done. They just haven't been done in rheumatology.
So
So,
can I
yeah, Peter, go
throw a
ahead.
few comments in there? So I think the Azokibep nanobody, they presented three different new IL-17 inhibitors at this meeting, and
Right.
they were all very much ho-hum, 60-40-20,
Right.
ACR 20-50-70, and they were all 40% NDA. So that'll make a total of what, six we're going to have now? So I would not, I'm asking the question, how many IL-17 inhibitors do we need? And if you're not 10, 20, 30% better, what's the point? I
I
get it,
agree.
we need more than one in case someone has an allergic reaction, as you occasionally see skin reactions, secukinumab, etc., etc. But how many? And I was just a little disappointed in these new nanobodies that are supposed to have increased absorption and get into tissue better, that they weren't actually getting better responses. And with the Trinetics thing, I hear what you're saying. They tried to do propensity scoring. They tried to match for lots of different things. And what was overwhelming was the size. They had 200 million people and
Yeah.
pulled out 1 million PSOs and a couple of 100,000 PSAs. And everything Eric is saying is 100% correct. You know, garbage in, garbage out. And really, they just showed that there was a difference in the reduction of the ICD code change from PSO to PSA, with one biologic a little bit better than the other biologic. And it happened to turn out to be similar to a previous Singlar paper that said the same thing. But I think if there's any way that that can be checked for accuracy, the sheer size of it's pretty overwhelming.
So isn't on one hand, we have the data about what works, what's more effective, what, you might want to hang, and nothing is overwhelming us there. But on the other hand, the Trinetics was attempting to answer the question, is psoriasis preclinical psoriatic arthritis? And can the evolution of disease to another 20-30% who develop PSA be altered by more aggressive biologic therapy? There's been reports in the past that are faulted for channeling bias, right? And there's no strong proof that aggressive treatment of psoriasis will stop the progression to PSA. So where are we in thinking on this issue?
Well,
Is it
well,
still up?
that's it's got to be prospective studies, Jack,
Right.
and they're doing it, but with a conversion rate of 3% a year, PSO to PSA. You're gonna have to follow a lot of people for a long time to answer that question, don't you think, Eric?
Yeah, I think that's exactly the problem, Peter. Is that these sort of retrospective looks, there's just too many confounding factors involved to really know for sure. You know, the challenge with the Trinetics database, I'm not an epidemiologist, but talking to some friends who did, you know, the challenge with the propensity score matching, Peter, is that you can't actually get under the hood with that system. You actually literally click a button that says, please propensity score match, and then it does it, and you really don't know what it's matching for. And so a lot of
Well, they
numbers.
listed They
I
listed in the presentation,
I understand
age,
that,
sex,
but the
disease
problem is that,
duration.
as you said, garbage in, garbage out. I mean, more numbers doesn't make it better if the data you're using isn't good in the first place. It just sends you down a rabbit hole. But you're absolutely right. It has to be done prospectively because you need to take a large, well characterized cohort of psoriasis patients who clearly have no arthritis or early in disease and follow them out for some period of time and see how many and on what drugs get arthritis. But that's going to take a really long time. As you do that, you can look for factors, whether they're genetic factors or other biomarkers that may help you predict that, but you need the clinical outcomes in order to understand whether any of those matter. And to try to do it retrospectively, people have been trying to do this for years, and it's too complicated because you have no control over what they received. If I have a patient who has psoriasis and didn't get psoriatic arthritis, is that because they never were going to, or because of the medication that was being used to treat their psoriasis? And I don't know.
All right, final word on these abstracts. Anthony, you brought it up. You have any final comments?
Yeah, I think a very interesting concept of this progression from PSO to PSA. We do know about risk factors. It'd be worthwhile studying the high-risk group people. And there was another abstract on high CRP being a predictor of future development of PSA as well. So simple biomarkers, but then studying in a head-to-head comparison would be the best way.
Okay, interesting concept. Eric, what's your one of your favorites?
I mean, I did think that the small molecule IL-17 inhibitors were interesting. The other one that's interesting that I think we don't know where we're going with it yet was an abstract on another TYK2 inhibitor. There's another, so we know that deucravacitinib has been working its way through. It's been approved, at least in the US, for psoriasis, and the sort of claim to fame, if you will, of these TYK2 inhibitors is twofold. That the way you can inhibit them is more specific. That even though TYK2 is essentially the fourth member of the JAK family, its mechanism is such that you can target it more specifically than you can with any of the other JAK family members, so you don't have some spillover. And the problem with JAK inhibitors, as we all know, is sort of off-target effects, and whether some of these cardiovascular and hematologic issues are related to the efficacy of the drug or other effects that you're not hoping to get. And the TYK2 inhibitors may kind of get around that. The other issue is the TYK2 inhibitor that IL-23 signals through TYK2. So the idea is you're targeting a pathway that we know is effective in psoriatic arthritis. It's not as good, though, interestingly enough. So deucravacitinib is, in the data that's out there, doesn't look, at least for skin, as good as the IL-23 specific antibodies. So even though it's the same pathway, it probably doesn't block the pathway to the same degree. There's enough that gets past it. This new drug now called zasocitinib, which I love because I think that's the best generic name for a drug that I've heard in a long time. It's Zaz.
The Takeda drug? The Takeda drug?
Yeah, zasocitinib, and so they presented some early data, and the thought there is that it's higher binding affinity and higher potentially, therefore you can drive the efficacy higher by giving a higher relative dose and still maintaining specificity. But honestly, it didn't look much different than the deucravacitinib data. So we'll have to wait and see. And we don't have a lot of data in psoriatic arthritis yet. It's all in skin, but they all carry nice safety profiles with them. So that's a plus. And I don't know that these are going to be drugs for people with the most severe psoriatic arthritis or the most severe psoriasis, but for people with sort of modest disease, an oral drug that has very few tolerability issues and not a lot of safety concerns is a potential win.
Okay. Anybody have a comment on the addition of the new tick inhibitor?
I think we're stuck in our country that we have to use two conventional synthetics over 12 to 24 weeks before anybody can get access to a biologic that's reimbursed. So methotrexate has to be one, and we're mucking around with leflunomide and sulfasalazine as the others. And we'd much rather use Ducra or even apremilast, which
Right.
has yet to be approved for PSA in our country because the government considered it wasn't effective enough at its cost to hold people up getting to better treatment. So I'd love to see Duca as the second agent we have to try before you go to a biologic, unless there's very bad prognostic features.
We have a Premolast. Don't worry, you're not missing out on too much, Peter.
It is the best selling of all the newer drugs because of its safety profile, and derms seem to like it quite a bit.
Yeah, they love it because you don't have to monitor anything. You don't have to check labs. You don't have to follow anything. You can just, as long as they don't have diarrhea, you send them on their way.
Dr. Chan, how are these
Yeah,
drugs?
really, yeah, really good safety profiles for some of these agents, and I think early in disease, where perhaps the disease is not as severe, in the mild to moderate cases, a lot of these drugs like Premilast, TIC2, I think would be probably where we would start them first before they went on to other drugs because of the ease of convenience of taking it. The binding story, the tighter binding, we've had this in the other areas, IL-17 with ICSI and with the nanobodies. Yeah, I think only time will tell whether that's going to make any clinical difference. Early data doesn't suggest that it makes a huge difference in terms of the clinical efficacy.
So is the psoriatic space shaping up to being a battle of the highs and lows, meaning that there's entry drugs that people are going to argue about, which always now has to include methotrexate, but in the United States at least is going to include apremilast, and maybe as the TIC2s get into play and also the JAKs, are they going to be lower end considerations? And then if you have more serious skin and serious joint, that you're going to be looking at the biologics, especially the 17s, the dual 17s, the 23s, the 1223s. Is there this
well,
polarized approach or no?
I think for the first time we get an individualized choice depending what domain you've got. And Alexa showed nicely that most people have three or four domains involved, and the majority have two, three, four. So if you're axial, you've got an individual choice. If you're skin, you've got an individual choice. If you're polyarthritis, you can individualize your choice. If you've got uveitis, IBD, individualize your choice. So I think the real question is, are we wedded to this methotrexate forever just because of history and just because of safety? If your wife got acute psoriatic arthritis with many joints and some skin, would you start her on methotrexate or would you go straight for one of the very safe 17s or 23s? For example, in Germany, they tell me the derms are allowed to go straight to secukinumab, not based on evidence, but based on a court case that they were successful in winning. The patient, that is. So, my son has a PSA, and he's certainly on one of the newer drugs to control his disease at a young age. So, I'm just asking you the question: are we wedded to methotrexate forever when there are agents that many people think are more effective, less associated with nuisance side effects, maybe more suitable in the long term, especially young people who like to drink alcohol in Australia? And what should the first be, depending on what your domain involvement is?
Is it not the individualized part is individualized to the prescriber and what I believe, as you're suggesting, Peter? Because the guidelines and RAPA guidelines levels the playing field on a lot of these choices, because they're really the trial designs proving the point. I get it. I think the problem was compounded by the PSA seam study, which showed the efficacy of methotrexate and put it back into play when many of us were trying to move away from methotrexate. Maybe not a safe drug in a psoriatic population, and maybe it's certainly not as good as some of the newer drugs is what we're seeing, but that study kind of changed the
I
choice.
think we got to get away from it, Jack, though. I mean, why are we using methotrexate? We're using methotrexate because it's been around for 40 years. I mean, there's a lot of
it's
stuff,
cheap.
I mean, that's been around for 40 years that we don't use anymore because things have moved on. And just because it's old doesn't mean it's better. I mean, I would challenge anyone to say that the safety profile of methotrexate is better than the safety profile of any of the biologics we're using, let alone the IL-23 inhibitors. And the real reason we're doing that is cost. And that may begin to change. I think, we're starting, you guys in the UK and in Australia are way ahead of us on this in terms of biosimilars, but we're starting to see it here. So, when you've got access to a biosimilar version of adalimumab, why do you do methotrexate then? How much money are you really going to save by putting on methotrexate and monitoring their labs and having to do a liver ultrasound on some percentage of them because the LFTs are high? I think we need to get out of that and get away from that.
If you have 500,000 people with psoriatic arthritis, do you start them off with a $80,000 a year drug or with an $8 a year drug? I
But
think
it's not 80,000. It's a $10,000 a year drug if you're using a biosimilar. And methotrexate is not $8 a year anymore. My patients are paying a couple $100 a month. If you just look at the actual numbers, methotrexate is a $2,000 or $3,000 drug, plus all the lab work you're doing, plus the potential, other workup that happens when you see hepatotoxicity. I don't think it's that much cheaper than a biosimilar adalimumab,
And
and I think we're going to see even more this whole issue of cost in another year and a half, or whatever it is when tofacitinib goes generic, because all of a sudden, all of the noise about not using JAK inhibitors may go out the window when it's actually one of the cheaper options.
I think no one has
Dr.
the
Chan can correct us.
right. Well,
Isn't a biosimilar adalimumab cheaper in the UK than methotrexate,
It's
Dr. Chan?
cheaper than the subcutaneous methotrexate, not the oral one. So I think this is changing. I mean, a lot of this is down to what the payers are saying. And we don't actually have a lot of evidence in the use of methotrexate in PSA, interestingly, but historically we've always been using it. But as you say, the price is coming down, and it is likely that we will be moving away towards using more biosimilars early on in disease.
okay. All right, Peter, give us something a little less controversial.
Well, I was going to give you, I knew you'd ask, so I thought about the themes. And the themes, I found six. The new IL-17s that you mentioned, telemonitoring. I think you know about what I feel about never examining patients ever again and missing pathology outside of joints, no matter how good the patients feel about it. This prevention of PSO to PSA we've already talked about. Biomarkers was a big theme. But there was a GRAPPA symposium and there was a presentation on this difficult to treat PSA. And what I liked about it is that they'd hived off complex to manage from difficult to treat. And I think that's an important distinction. And it even comes over to the AXPAR space, where one of the new ASAS guidelines is if people aren't responding, reassess the diagnosis rather than cycling forever through expensive biologics. So I think there's parallels. And the D to T definition, I think they're going to end up with is fail one conventional and fail two biologics of a different MOA. And then you've got this label difficult to treat, which has to be reworded as treatment refractory, or the patients aren't going to be happy and say, I'm not a difficult person. What are you saying to me? So anyway, I think it's an interesting initiative. Complex to manage means a lot of non-musculoskeletal pain that has to be managed equally as well, whether it's cannabis, whether it's pregabalin, whether it's amitriptyline, whether it's diet and physio and the GLP-1 drugs. We can't ignore that, and it's just as important. And the implication is if you can identify the D to T before they've already failed two biologics, maybe combination therapy needs to be tested, et cetera, et cetera. So I think the whole movement is only going to be relevant if it changes management at the people we know are going to end up bad prognosis. So I thought that was an interesting area that's sort of a hot topic at the moment, awaiting definition. And the other one that I was going to mention was the GO-LAPSA study, where, again, asking the question, is a TNF plus methotrexate and some steroid any better than methotrexate and steroid alone? And I must say, I was so disappointed in this study that they wasted this fantastic opportunity by filling all the patients up with injected steroid at baseline. So you only have to have 2 swollen joints and 1 enthesis to get in, 40 in each arm, pretty small. Took them years to recruit as it was, early untreated PSA, and they gave him 120 milligrams of injected steroid each arm at the beginning of the trial when they started the methotrexate on one side and the golimumab methotrexate on the other. Then they repeated another 120 8 weeks later. And the group without the TNF got twice as much steroid as the group that were on the TNF. And then they say there's no difference in between the two down the line. Who's surprised? What a waste of a fantastic opportunity to see if starting the TNF on day one would make a difference. Because that was the conclusion, that they couldn't show significant difference. But when you looked at it, there was a big difference in steroid. The numbers were small, and there was even sort of trends like to separate them, even given all that stuff. So I was a bit disappointed in that study because it didn't answer the questions we wanted to answer. For the higher responses like ACR 70, there was clearly a difference that was significant. But even at week 12 and 24 with the TNF added, MDA was pretty equal across the board. So missed opportunity as far as I can see.
Let's go back to the distinction of difficult to treat and complex to manage disease. Anthony and Eric, what does that do for you in the future management of psoriatic disease? Anthony?
I think it's the important point here is to revisit the diagnosis, and I think the difficult to treat patients often we have to take into consideration the comorbidities. So a lot of these patients, we are using scores that might be measuring fibromyalgia, or there might be an effect of obesity or smoking. So rather than cycling through biologics, one has to kind of take into account some of the not only extra musculoskeletal manifestations, but comorbidities as well. And so making the distinction between complex and difficult to treat is quite important.
Eric?
Yeah, I mean, I think that's huge because they're two different issues, right? The question is whether you have a disease process that's not responding to what you're treating them with, whether it's a biologic or a combination of biologics or a different biologic, or is there something else at play that's not going to respond to whatever you change them to? And I'm as I've sort of to compare, as I've looked out there, I'm a little disappointed in what's happening in the rheumatoid arthritis space because they're kind of muddying the two together. And I can't speak for Anthony and Peter, but I not infrequently see a patient who's come in for another opinion who's failed 3 or 4 or 5 drugs, and the first question I always ask, and I tell my fellows to ask, is, are they actually treating the right thing? Is this really, have they not found the drug that's going to work on their disease, or is this central pain or something else that no drug is going to work on? And I like the approach that the folks at GRAPPA are taking in psoriatic arthritis, because they're really trying to separate those two out, and that the complex to manage includes fibromyalgia, kind of central pain, includes people with osteoarthritis. It's not, those are not going to respond to a different biologic, no matter, or a different pathway of biologics. And if we're going to start looking at approaches to these folks, we need to make sure we have a sort of a coherent, consistent pool of patients who are, at least potentially likely to respond to whatever we're going to try. So I do like this approach, and I think it does have legs, and they're still trying to sort out, as Peter said, how many drugs do you have to fail and what makes that call. And that's sort of the sort of fine tuning, but the big idea of separating out difficult to treat, inflammatory disease versus complex to manage that takes in all the other pieces that we're dealing with is huge.
And I left out one key point. Sorry, Jack. I left out that the definition of difficult to treat includes imaging evidence of inflammation, whether it's ultrasound or MRI, but not labs. So that is what Eric's saying. You have to have evidence of active inflammation to be a DTT. Yeah.
So the hard and expensive to treat just got more expensive by throwing in MR and ultrasound. I don't know that that's an advantage. I think you can hang your hat on other ways of assessing inflammation, but the one you don't want is empiric trials to see if an anti-inflammatory agent is going to benefit those who are not responding. So I'm a little concerned about the clinical trials that we've seen in the past showing poor survival of expensive therapies, biologics and targeted synthetics in both psoriasis and psoriatic arthritis, such that when you look at 3 years of therapy, less than half the people are taking the drugs. And I want to know from our experts here, is that because these are the D2T patients, or is it because we just have too many options for treatment and people are switching off because they can't? Anybody have a strong opinion on that?
I do. I think a lot of it's the latter. We've talked about this in our psoriatic arthritis clinic. I work with a dermatologist, and we've been talking about this lately as we see people. And the first thing is that the idea that 2-3 years out, 70% of people are off the drug you start them. That doesn't feel right. I mean, that's just not been my perception, but it is what it is. They're getting that data. But at least in the US, what I'm seeing is I think a lot of it is expectation. That we've got so many drugs and so many good drugs that patients are getting to the point that they're expecting to be all better. And I have people come in and say, this is working well for me, but I've got this one little piece of psoriasis on my elbow, or, this knuckle is hurting me a little bit. And I try my best to talk them down and say, look, you're not 100%, but boy, you're 95%. And I don't know how much we're going to gain by starting all over and switching to a new drug. And you may be worse. But I think people are, especially in the skin side, that these drugs have begun working so well. People see the promise and they're like, why can't I be clear? Let's get me there and let's switch to something else. I'm not happy where I am. And I don't know that we can expect every patient to be 100% controlled. I just don't know that that's the right target.
Yeah, I think the drop-off is mainly because it's such an heterogeneous condition, and we are treating different domains at different time points: early onset, late onset, polyarticular, spinal, and what's really important is the assessment of these patients before and after treatment to ensure that we've got the right kind of phenotype of these patients, and hopefully we will be able to then select the right agent. At the moment, it's very much clinical, but hopefully with the future development of biomarkers, we hope we'll be able to choose. We become victim of choice, that we sometimes stop assessing people because we know that, hey, there's another one we can go to. And then we get into this cycle. And this is what we need to do. We go back to the clinical, examine them, check, make sure it's psoriatic arthritis, not osteoarthritis, and then what particular domain. Is it antithesis? We have to just use that a bit better.
Peter, will we do better if we treat by domain and make it personalized as you suggest?
Well, I do what Eric does. I tell them we have to squeeze every last drop out of each agent before we swap and change. Because firstly, it's been very hard to get access, and then you got to make sure that non-response is really something to do with non-response to that therapy. But I do think the PSA patients are different to RA. and the numbers prove it, that they churn much at a higher rate than the RA patients. And I wonder if it's because we often treat late, not early. And I wonder if it's to do with choice. And I wonder if it's to do with flares from intercurrent infection and a million other life stress events that makes it just as difficult to treat PSA, and that it's a combination of disease almost getting resistant to what you've used, and churn because you have choice, and churn because you have flares and things. So it's difficult. There's no easy answer to why they churn. They always have a high placebo response rate anyway in all the clinical trials compared to RA, and they churn more than the RA patients do for some reason.
I want to ask our panel, we kind of went over the sonelokimab, the dual AF inhibitor of IL-17 kind of quickly, and this along with bimekizumab on the precipice of maybe being approved in PSA. Is there any belief from the data that we have that these drugs are going to be better arthritis-wise? We know they're going to be very good skin-wise, right? And the head-to-head trials in psoriasis show that. But are they going to be any better arthritis-wise or any safer? And does anybody have an opinion about this?
Well, I think they're going to end up, the 17s in many countries, like NICE in the UK, are going to make people use a TNF first. And the TNF-IR numbers with bimekizumab is pretty impressive. And I got a feeling that in many countries, it'll slot into that position, not because of what people want, but because the regulators will insist. So at least to be able to say we've got the best TNF-IR numbers in any study, but it's hard pressed to show a difference that blocking F makes compared to just blocking A by itself. And the downside seems to be a little bit more fungus. I certainly don't think there's any more IBD, but I'd be interested in the other panelists' just thoughts on that.
Sure.
Yeah, I think we select carefully, so this is why we probably don't have many people with IBD who will be put onto this treatment. But in terms of the nanobodies, it's too early to say. From what we know, certainly at 12 weeks, it looks impressive in terms of its ACR 50 response. Whether it will fall into TNF-IR, it probably will be where we practice currently because of the costs.
Yeah, I don't think it's more effective than the existing IL-17 inhibitors. I mean, the problem is we have no comparative data. But if you look at their two phase 3 trials, they don't from the joint side, they don't really look very much different than ixekizumab or secukinumab. I mean, Peter's right. The one sort of thing they might hang their hat on is that it seemed to perform a bit better than the TNF IRs, but that's a different trial than the TNF IRs that were in the ixekizumab trial or in secukinumab trials, and I'm a little bit cautious about sort of making too much of that. And I'm also not sure that inhibiting IL-17F, that there's some mechanism why it should work better though. So I mean, there's no rationale for why it should be better in TNF-IRs necessarily. That the promise of IL-17F inhibition is really for skin, and it works there. It's a very potent drug in skin, but I don't think there's a heck of a lot of difference, if any, on the joints. 17, that's no different than the other two we already have.
Okay. Anybody have any last ones you want to get in before we conclude our panel?
Yeah, if I got one, it's more for SPA this time. If I can share the oral presentation 132. This was the treat to target approach in SPA, which I thought was interesting. It's people very early in disease, 1 year disease duration, and they put them on golimumab versus anti-inflammatories. Once they got onto remission, they came off the treatment, but very quickly 84% of them flare. But the time to flare was a bit longer in the golimumab group, 155 days, versus the NSAID group, which was 61. What it showed is that male patients, low BASDI, and non-smokers were the people who were more likely to get into remission. So I thought it was interesting to study this early in disease. Most of our studies are 8-9 years of disease duration.
And Jack's already mentioned, Eric's already mentioned the JAK inhibitors. Well, the Chinese presented AS data and PSA data of a RA data of their own JAK1 inhibitor, which looks and tastes and smells and feels like a JAK1 inhibitor and has results that are unbelievably good and a safety profile that's also unbelievably good. The higher dose didn't have any anemia, and in fact they don't show any zoster results. So when you ask them, yes, they had a couple of cases. So we need those molecules out multinational studies, but they'll be quite happy to do them in China and not see the rest of the world. They've got a big enough patient population. But Eric's right about tofa. They tell me there's 8 generic tofas in Buenos Aires.
Yeah, my understanding in India right now is that generic JAK inhibitor is the drug of choice for RA at this point because it's incredibly cheap. There's a million generic options.
And I've actually seen a publication where they compared the generic tofa against the originator tofa, and like a biosimilar type study, and it was equally as effective and had the same profile.
Impressive. At the conclusion of the meeting, didn't GRAPPA have its meeting at EULAR, Eric?
They had their meeting beforehand, and I don't recall that there was anything dramatic that came over. They have a number of projects that they're working on, both educational and this whole idea of defining the difficult to treat patient as really as a pathway to then doing some clinical trials in that population to really understand the best treatment approach.
Still think the GRAPPA
There's a big project. Sorry, there's a big project on gender and why there should be differences in baseline disease activity and response to therapy.
What's
males
Jenga?
to females.
Game of wood blocks. I don't know what you're talking about. Jenga?
Pardon?
Gender.
Sorry, gender. So females have higher baseline disease activity, respond less well.
Okay.
And there's a very giant project underway to work out why that should be and whether we should stratify all clinical trials going forward for gender.
Right.
There's a big biomarkers collaboration called Hippocrates. There's a big combination study underway with GRAPPA, combo 23 TNF versus 23 alone. So there's a number of things underway that are trying to answer some of the issues that you've raised, Jack.
Okay. All right, folks. This has been a lively discussion. We appreciate your oversight and review and your careful attendance at all these sessions and educating us on what's happening in psoriatic arthritis. Have a good evening.
All right.
Thanks a lot.